We're on wait line. All right.
Good afternoon, everyone, and welcome to today's edition of Black Health Trust. We're so happy that you took some time out, your holiday time with us as we discuss issues affecting our health issues affecting our community. Without further ado, Dr. Randall Maxey.
Good afternoon, everyone. I hope everybody is safe during this storm that's raging across the nation. And I wish you a happy Memorial Day. I know everybody wants to get to their barbecue. We have a guest speaker this afternoon. I don't know what the weather is on the East Coast, but Dr. William Lawson is going to be our speaker. He's having a few technical issues. Let me know when he's on, Simon. I just spoke to him. But we do know that mental health issues are ravaging our communities, and especially communities that don't have good access to adequate care with any healthcare issue, let alone mental health. And so therefore we welcome Dr. William Lawson. Dr. Lawson was formerly the chair of psychiatry at Howard University College of Medicine. He's been the chair at several other esteemed universities across the country. He is currently full professor of psychiatry at George Washington University in Washington, D.C. And he's been our presenter on several previous occasions here. And he is a senior mental health person in the country, and we respect him highly. Is Dr. Lawson on yet?
Dr. Lawson's right here.
Dr. Lawson, the floor is yours. I understand that you have a hard stop at 1:45.
Yep, just trying to make sure I got the wrong one. Excuse me while I quickly sort through the appropriate oops, okay. I will have the right slide up very soon. And there we go. Yes. And is it showing at your end? Is it visible at your end? Hello?
We're here. We can hear you.
Can you see the slide?
Yes.
Gotcha. Okay, talking about old issues in mental health. This is me. I think you presented Dr. Walks have always done such an outstanding, excellent job in telling everybody who I am. So I'll let this go on. And just note that again, this is Mental Health Awareness Month. And it's Mental Health Awareness Month to help folks recognize that mental illness, not only mental illness is an issue, but it's interesting. We don't have a chronic disease, or well, we probably should, Awareness Month, but it still shows that mental health is taking a backseat to general medical conditions. The COVID issues I've presented previously has uncovered old unresolved issues in mental health, in substance abuse, and of course in chronic disease. The impact right now, I won't say thanks to COVID, but COVID has reminded us again that death rate among people of color is rising faster than our white counterparts. We're seeing a lot of deaths in terms of drug overdoses. And what I don't include here is that in many of our cities, we're also seeing deaths from homicide. These are not a result directly of a specific illness, other than the role of mental disorders in terms of contributing to these problems. And part of it has to do with the fact that there's still a lot of stigma associated with mental illness. I was just giving a presentation at a church in which we were talking about substance abuse, and that one of the barriers to getting some church involvement is that we looked at people who use drugs of abuse are considered less than the rest of us. Also, often when folks come in and showing the presence of mental disorders, I've seen folks actually let out of the church or let out of public meetings. Yet at the same time, if that same person had problems related to a seizure disorder or cardiovascular disease, they would be given a nice, comfortable seat. And part of it has to do with the lack of literacy in our community, in the country as a whole, but especially in our community, about mental health and substance abuse. And on top of that, confounding that, because of that lack of literacy, we have a lack of access to effective treatments, despite the fact that they're being developed. And it's exacerbated by the realities of history. Dr. Chapman and I have continued to talk about how the consequences of the mental health and substance abuse has been addressed in the past, has been continuing to be a problem, exacerbated by racism, and also by these continued disparities in access to care in our communities. One of the issues, of course, is structural racism. We've talked about that ad nauseum. The point is exactly the same, and that is, and it's not that people just going around and not liking Black people or saying, I don't like you, you don't look right. It's much more that's built in our system, elements that lead to a limited access to care. There's the whole phenomenon of redlining. By the way, it's still going on. It's just under a different name, in which people of color can't live anywhere they want to. And actually has been exacerbated in recent years. That was often limited to income areas that historically have low income and also are increased risk for areas in which there's pollution in the environment. Yes, sir. Hmm? Yeah. It's not going forward.
Right.
What should I do?
Try to change them now. Try to press it forward.
Okay. Did that change?
No.
This is Dr. Walks, Dr. Lawson. I think you've got the slide with the first Black psychiatrist, Solomon Carter Fuller. And I don't know that you've clicked on the slide deck that you want to use yet.
Yeah, I clicked on the slide I want to use, just didn't move.
Okay.
So I'm not sure how to change that.
Can you
Except
send a copy of that slide deck, Simon? Give him your
sure.
email.
Let me see if I can. Yeah, I can do.
If you close it and reopen it, it should change. It should fix it.
Yeah, let me try that because I just changed computers. Mine crashed recently, and now, oops, yeah, I see that's the old one. Good. Yeah. Okay. Okay. So we'll close everybody. Stop. There's a shared windows closed, and then okay, and then I will now share screen again. Oh, I see it's still wide. It's still spinning ball. Yeah, I will try to save it. Let's see. Again, very quickly. Okay. Now send it, what should I send it to? Who?
Simon, give me your email.
I can't look that up. Greg Simon.
Or send it to me. I'll send it to you.
I sent it. What's it?
Randall.maxi02 at
Yeah, I
gmail.
got Max. Yeah, I got you. Maxi. Randall Maxi. There we go. There we go. And then I am now going to forward it to you as attachment. And let's see if we can forward it. So I'm replying to you and attaching here. And it's loading. Stop loading. Send. And I presume you received it. Did you get it?
That's it.
Oops. We'll do it again. I sent it to randommaxi@gmail.
Randall.maxi02. I just got it.
You got it? Okay.
Yep. Mhm.
Yep. So let me save it.
Hey, Simon's on his way to you. In the meantime, Dr. While your slide deck is getting sent to Simon, what are the most common mental diseases that we experience in our community?
Yeah, I mean, the usual that is okay. So it's come up on mine. Did it come up on yours? Did it become visible on yours?
Not yet, Dr. Lawson. We can't see your screen.
You cannot see my screen at all.
But you can go ahead. What Simon will be putting it up in a minute. You can start.
Okay. Yeah. Probably the two, of course, are depression and anxiety. But the important thing, as I mentioned before, is the problem of unrecognition of these problems. And part, as I mentioned before, was stigma, lack of literacy, and lack of access. And checking. And because of the historical issues, the structural issues, we mentioned redlining, the problem of misdiagnosis and underdiagnosis, and also what I call wevering. And that is that because of our experiences, many of us, not only do we physically age, but we mentally age much faster than the general population. Yeah, let me know when we got the system on going again.
Okay, looks like we're up.
Yep. Okay, where are we? Where is it on the slideshow now?
Looks like the third slide, the impact,
Okay,
which you covered.
right. So we got the impact, results, the exacerbated by pre-existing issues, moving on, structural racism, and again, unabashed reminder of my book and the issue of disparities in diagnosis, treatment, access to care, greater than any other ethnic group, by the way, which is extremely important as well. And also the problem of increasing. That is that the disparities are increasing, and it's probably related to the fact that income disparities are also greater now than they have been in the past. While we're making more money, our family incomes have really been either stagnant or growing much slower than the general population. And the problem of misdiagnosis, that is that we are much more likely to be diagnosed with schizophrenia, even when folks have PTSD, bipolar disorder, or depression. And because of misdiagnosis, treatment delayed, refused, novel treatments are viewed with suspicion. And what I'm finding, and Dr. Chapman has also emphasized this point, so many people are seeking treatment, but using drugs of abuse. The same people that say we don't want to take that medicine that come from our doctors will take essentially drugs that affect the same neurotransmitter systems, but are sold on the street. Difference is that the street drugs, frankly, you don't know what you're going to get. Secondly, there's also the problem that there's also an admixture in the drugs. I've had several patients who said that they were got some street cannabis that's not really marijuana, and yet they eventually developed psychotic symptoms because they had other hallucinogens as well as THC grade in it. And I want to go back to a study that unfortunately has been replicated so many times, and that is that we looked at our primary care clinic at Howard, and by the way, this was done at the primary care clinic at Morehouse, primary care clinic at Columbia University. And what we find is that post-traumatic stress disorder is common in inner city areas. It's extremely common. We're not talking about mild people say they're under distress. We're talking about folks with a full-blown syndrome that you see in combat veterans, where they're having flashbacks, where they're having fearful going into strange situations, where they have hyperreactivity to stressful situations. The full-blown thing. And it's probably more common than in the combat situation, and also has the long-term consequences as well. And in addition to that, it's often comorbid with major depression. You mentioned, I mentioned anxiety and depression. PTSD has been moved out of the anxiety nomenclature, gave its own area. And so you have to say that in many of our communities, especially in inner city areas, PTSD is extremely common, but is often under-recognized, and even less so of folks being treated in a specialized mental health or mental setting. They often end up in self-treatment or getting illicit treatment from drugs of abuse, or simply suffering in silence. And now, can the next slide, is that visible? The National Mental Health Association survey. Because I just want to know some points about this. An old survey. It has been replicated. And what it shows is that more than half of all Americans believe that depression is a personal weakness. That's one of the issues in terms of lack of health literacy. We recognize that major depression is in fact a brain disorder that is not inevitable. You can get sad or depressed in terms of being exposed to loss, but we're talking about depression in which symptoms are persistent for several weeks, most of the time, where folks have problems with eating, sleeping, where folks can't function. And often, rather than recognizing this as something that is an illness that can be treated, folks are discouraged from discussing it. It's stigmatized, showing that you're weak, and so they don't discuss it. And only less than a third of folks believe that it's a health problem. Most of them, third also said that they can handle it themselves. Also, don't recognize, what we find in many communities is that folks do not have often the willingness to say they're sad or unhappy. Instead, they say that the job isn't right or life is terrible. And they also do not recognize that they may have changes in eating, they're changing in sleeping, which often is a sign of depression. And then it used to be a third, it's up to about 40% now. People who will take medication for depression compared to most of the general population. And also, there's still a lot of folks who see an inconsistency between seeking help for depression and also having strong religious beliefs or Christian beliefs. We're not seeing that's changing. That you can have a lot of faith and pray and still get depressed. And I've worked with a number of ministers who have been despondent. So the important thing is that, unfortunately, prayer and faith may have some protective qualities, but unfortunately, it's not completely protected. And as a result, folks may not get the treatment that they need. This just shows an old picture from some research just showing that changes in schizophrenia. We now have our imaging has improved enough to show that depression, anxiety disorders, as well as schizophrenia, bipolar disorder, we can actually find actual changes in the brain. It's not that these changes are permanent. It's not that these changes are necessarily genetic, but we do see that with functional imaging, post-max, PET scanning, we can actually see brain changes. In post-traumatic stress disorder, we're going to actually see shrinkage of a part of the brain called the hippocampus, which is involved with coordination and also memory. So these are disorders that are, for want of a better word, brain diseases. Not to say they're irreversible or can't be changed, but it's more evidence that we need to develop ways to let folks know that this is not a weakness, some sort of psychic weakness or spiritual weakness, but actually a way in which our bodies are responding at the level of the brain in terms of stress or unhappy moments or ongoing difficulties. Similarly, we've also found that people who abuse drugs, we find and there are changes in the brain, not from the drugs themselves, but that may predispose to the use of drugs. And so these agents may help to regulate, restore some function in the brain that leads to this difficulty in treating drug abuse, and also the fact that drug abuse is reoccurring. So again, the idea is often that drug abuse is some sort of reflection of some conduct problem or weakness in the person's spiritual life, when in fact, we're now finding evidence that drug abuse itself is in fact has some biological undercurrents. Now, there is an attempt now to try to market a test that's supposed to be able to identify potential drug users. Some of us have come out against that simply because just because the person has a potential or risk factor doesn't mean it's going to happen, or that we can't develop more preventive ways to address it. And also because of the whole stigma issue that's involved with saying that a person may become a drug abuser. In addition to that, just want to again emphasize, this is a slide that Dr. Chapman has some more recent data showing that overdose deaths, unfortunately, have not dropped. They have continued to, people are continuing to take drugs like fentanyl, and to the extent that they die. Dr. Chapman gives multiple cases of people literally sitting in his office waiting to see him and stopping breathing. So So the use of these drugs, these folks, many tell themselves that they're not addicted. Also, they go right into loss of the ability to breathe without much distress, and then quickly pass into unconsciousness and death. So this is an ongoing issue with synthetic opioids. They have now become a major problem. And again, we used to think this is a young people's disease. No, it isn't. Some elderly people use these agents in terms of dealing with chronic pain, chronic anxiety, and we also find that it doesn't really relate that well to income. These drugs are now cheap, and they're also very, very available. They're saying that we stop immigration at the border, these problems disappear. Well, some of these folks can take the ingredients and make it in their bathtub at home. These agents most of the use of these agents literally come from homegrown factories or people in the community. And they're involved in most overdose deaths. And again, because these drugs, one, make people feel good, two, can reduce pain, but three, far more potent than the older drugs that we had, such as methadone, than heroin, and if you, morphine. And if you what Dr. Chapman's research team, what we're seeing is that folks who are getting along with maintenance dose of morphine and heroin switch to these agents and they die. So this is an ongoing issue, not discussed as much as we like. Simplistic solutions have been proposed, and it's something we must address. So what can we do? Well, it's confounded by the other problem that you often see that these are comorbid together. People with mental disorders often end up using drugs of abuse, and as a result, there's a diagnostic problem, worsens the mental problem, leads to permanent neuropsychiatric complications, increased risk of risky behavior. Some of these suicide risks because people are making unwise decisions on drugs of abuse. Problem, unintentional injury, i.e. car accidents, job injuries, and so on. And good evidence that it's related to some of the chronic diseases that have reemerged in our communities. There's greater stigma on people that have both problems and also more homelessness and can't keep a job if you have a mental disorder and if you have substance abuse. In addition to that, let's just go back a little bit. This again, our current system is a problem. Back in DC, it's lauded it because we now, most folks in DC have access to some sort of insurance of some sort or some sort of care if they can get it from mental disorders. But what we find in our current system is not so much as care can be gotten or they have funding for it, but there's such a disjointed system because of the stigma, the lack of knowledge, the stress, and as these drugs, these problems sneak up on people, and also because they may have to require referral from a general practitioner, they go into a system that is inefficient. It may not end up as a general practitioner. It may be seen first by a policeman, or in the correctional system. And so people often don't receive treatment, even after they've been diagnosed by a mental health practitioner or a general practitioner. And as a result, they may end up in long-term treatment or drop out completely from care. Just again, remind folks that mental disorders are not a benign condition. In addition to overdose and drug abuse, we also have a high risk of suicide. This is Don Cornelius, who died from a self-inflicted gunshot wound, made good money, but at the same time had an underlying depression. And is the founder of Soul Train, and they regularly have a regular program discussing the issue of suicide. which is beginning increasing in African American youth. We used to have reportedly very low rates of suicide, although if you go back, you find suicide rates were high all the way back to slavery times. We'll also find that the suicide rate among young Black men has significantly increased in recent years. And part of it is that there's a lot of unrecognized suicides, not only from car accidents or from drug abuse, but also get involved with the law, knowing that some law officers will fire away when they see a Black person holding a gun or even a toy gun. And I've frequently heard folks from the community say, we're not afraid to die, and looked at as a value and not as potential pathology. Also, to be on the stress is better to be bad than to be mad. If you're having problems, well, I'm bad. So, problem is lack of access to culturally competent therapists, lack of access to evidence-based therapy. I'll say more about that. Lack of contact with specialists, and better to be thought than bad than mad. There's a very interesting book by Metzler, who carved out the point that the concept of some of the mental disorders like schizophrenia basically became Black diseases and were used to marketing because we need to have medication strong enough, as they say, to deal with these folks. Then there's the case of folks who otherwise are not recognized. They have no history, they have limited history of mental disorders, but end up in the correctional system. This as a result of Chandra Bland, who's started a new job, refused to extinguish a cigarette at officers' request. He removed her from a vehicle, arrested her, locked in jail, and 3 days later she was found dead in her jail cell, presumably as a result of suicide. It led to some legal changes in the Texas system, but not necessarily in the national system. Or the sad case, the facility in Petersburg, Virginia, in which a young man who was mentally ill was thought to be out of control, and literally the officers piled on him, and he eventually died. So unfortunately, people who have mental disorders generate all kinds of feelings, not only for the general community, but also for law enforcement agencies. And we now know that the African American inmates who are in the correctional system are less likely to get treatment, if at all. And we discussed that previously, and that there's a significant number of folks still in the correctional system that after deinstitutionalization, when we say we'll get people out of these mental hospitals and put them in the community, they end up on the streets or in the correctional system. So in general, folks who have mental health problems are more likely to be incarcerated than treated. And the correctional system, more and more people, mental illness and co-occurring substance abuse, and most inpatient psychiatric facilities. When you read the literature, you would almost find that there's almost a vacuum in terms of information about what happens to folks who are in these settings. Dr. Nell Prim, among others, have written about it, but that's more the exception rather than the rule. Then there's the primary care issue. Many times our folks do not want to see or aren't able to see specialized providers. They end up seeing folks in primary care who are trying to see about a patient every 5 to 10 minutes, and who many times simply can't get that kind of detailed information to identify mental health problems. We find that depression is common, as already mentioned, post-traumatic stress disorder is common. We also recently found that people with bipolar disorder, manic depressive illness, are often in the correctional system, misdiagnosed, and not receive the appropriate treatment. to end up treated as depressed when in fact they're not. So what's the key to all this? How do we address it? We need legislation, we need policy, we need resources, we need education, and we need clinical models. Good news, treatment works. Treatment works for mental health disorders, treatment works for substance abuse, and also preventive models that are working. When the good news emerging recently that disorders such as Alzheimer's disease, we now actually look at preventive models in Alzheimer's disease. Eating well, keep your brain stimulated, and so forth. It's also a general rule for mental disorders and substance abuse in general. In addition, we got to focus on, there's just no good evidence that being in the correctional system is good for you if you have a mental disorder and substance abuse. And yet, we still have a system focuses on punitive. Well, then, if we have treatments, can folks get it? An unfortunate case is the case of, we recognize, for instance, that the postpartum depression is very common in the African American community, that many, as some women develop postpartum psychosis, extremely common. But the bad news is that there aren't that many treatments, very little research. We recently developed an agent that was got approved. We were involved in the study, had very good results, treated it very well. But when it first came out, what happens? It was only able to be given intravenously. Whoops. The company finally came out with oral form. But the problem was that is extremely expensive. We had to go through prior approval. By that time, hopefully, the mother would have gotten some sort of support. But unfortunately, it has not been. So this is important because it shows we can develop new mechanisms to address these, but we can heck of a time get them available in our community mental health centers or in the African American community. Similarly, we have effective treatments in terms of substance abuse on community programs such as AA, which is often African Americans are underrepresented, NA. There's effective pharmacotherapy. We down buprenorphine, among others. We got effective psychotherapies, which a lot of people, frankly, don't believe, but which we remind them. If you look at effectiveness of hypertensive medications, the effectiveness of diabetes medication for those disorders, you expect them to have relapses every once in a while. Certainly when this happens in terms of substance abuse, we say that the therapy isn't working. So we need to look at the same kind of standards for treating problems like substance abuse as it do for medical illnesses. Then we have contingency management, support groups, motivational interviewing, which you can teach most providers to use, as well as strong peer support motions. So you don't need to have high income providers involved. And this is just showing you some data showing that methadone treatment reduced the death rate for people who had substance abuse. We recently had a street named after Benny Prim in New York for his contribution to demonstrate the effectiveness of methadone. Not world's best treatment, but it laid the foundation to recognize that pharmacotherapy combined with various kinds of psychotherapy and support therapy can be effective. So we find, unfortunately, that in the correctional system, we are still less likely to get treatment and little hope of receiving treatment. So what do we need to do? We got to get a cultural overlay to address mental disorders and substance abuse. We got to have psychoeducation for medical adherence for the patients, but also for the community. We got to have vocational rehab. We now recognize that recovery does occur, that people that have substance abuse programs, mental health programs, eventually with ongoing treatment, they can return to previous functioning and they can work. And we got to have receptive support groups by family and peers, which is often less common in the African American community. Plus, we got to get we know, contrary to what some of us have said, find that African Americans and Latinos do well with same-race providers. Coach concept of race matching. That's better health outcomes, better also health outcomes with white folks too. But we don't have enough doctors who are Black. It hasn't changed in the past 120 years. I just scratch out physicians and put psychologists just as easy, and it's the same thing. Thanks to such people, Solomon Carter Fuller, the first African American psychiatrist, as well as Alta Stewart, who supplied this, who was the first president of the American Psychiatric Association. We're making some changes, but it's small. Still got a long way to go, and we got to work to involve physician as a service provider in partnership with counselors, social workers, psychologists, lay people, and we got to get them administrators as well. So we need to have an all-court press kind of determine these issues. And I just want to again give a shout out to Zion Baptist Church, as well as others in the DC community, which are working overtime to try to provide service information to the African American community. And also, not only information, but also some churches are in fact providing support groups and others. So there's a role that churches, barbershops, beauty parlors, and others can do to provide ongoing support. We did it with COVID. It was amazing how organizations come together. We can now do it now.
Don't move. Don't move.
Thank you. Okay. Any quick questions before I disappear?
Well, thank you so much for, again, an excellent lecture, Dr. Lawson. And we did promise you that you could get to the event that you have a hard stop for, but I have one quick question. Every week we hear of some person claiming to have mental health issues that gets killed by the law enforcement. What's your opinion on that? Should they try to have non-lethal shootings? Or what's your position on that?
One is education, and we're trying to reduce the stigma. I work with a program at the DC Department of Police Department to help try to reduce that, as well as also had programs in Austin, Texas. So I think, and the others is to also work with the community. Police reflect the community they are in, and if they're in communities in which people say, these crazy people, we got to do something with them, like get them out the way. It filters into how you reinforce the police department. Non-lethal weapons help. I've worked to teach policemen police women how to use martial arts as a way of restraining people rather than simply shooting away. But there's I call cowboy mentality: shoot first, ask questions later. You can resolve things in terms of guns. That's pervasive and keeps both from having a widespread acceptance of looking at non-lethal ways of resolving conflict resolution. Other countries have done it very well. The U.S. is way behind. And also behind this also is, frankly, African Americans are perceived of as different, and African Americans who are mentally ill are perceived of as particularly potentially lethal beings that need to put down in a way possible.
Again, thank you so much, Dr. Barbara Neighbor-Stevens. Dr. Walsh, we have a quick final statement and question. We promised him he could go to this affair he has.
This is Dr. Walks. Dr. Lawson, I know it's a very secret fair you have to go to, so I'll see you there in about an hour. give you time to get everything ready. I'll be over. No, just in all seriousness, yes, I will. And also in all seriousness, thank you, Dr. Lawson. You are truly a gem, and we are always happy when you come and share with us. So thank you very
Well,
much.
love to spread the word here.
Dr. Neighbor Stevens?
Dr. Lawson, thank you for sharing your afternoon with us. As this is such a massive subject, we have still only scratched the surface, and I look forward to your return where we can start digging a little deeper, because there are many, many questions I could ask that I won't ask.
Well, thank you so much, and Dr. Lawson, and thank you, Simon. Everybody have a great Memorial Day weekend. Have a great day.
Good day, everyone.
Bye.